All right. So kids move a lot when they're awake, and sometimes they can move a lot when they're asleep. Sometimes that could be a problem. Let's see if we can figure out when that would be. Children are rarely ones to complain about strange behavior. After all, how would they know any better? Therefore, it's usually someone else who notices it. These movements may stem from a behavioral or psychophysiological disorder, or even a seizure disorder. Stereotypy is a continuous, repetitive, purposeless, or ritualistic movement, posture, or utterance found in patients with mental retardation, the autism spectrum, tardive dyskinesia, and stereotypic movement disorder. Uh, just it's just something someone does over and over and over again. Stereotypies may be simple movements such as body rocking or complex, such as self caressing, crossing or uncrossing the legs, or marching in place. Behaviors that are almost the same every night or that are very stereotypic may be signs of a seizure disorder like finger twitching or singular limb movements. Like usually kids, if they move or twitch in sleep, it's the whole body or bilateral. Both sides are doing it. When it's one side, that's different. That might be a brain disorder. Um, Parasomnias are, yeah, remember that kids are weird and parasomnias are pretty common in children. Sleep related rhythmic movement disorders characterized by repetitive, stereotyped, and rhythmic motor behaviors that occur predominantly during drowsiness or sleep and involve large muscle groups. These are distinguished from the movements associated with parasomnias because these are simple stereotype movements. Parasomnias usually involve complex behaviors. There are a few subtypes of rhythmic disorders. Body rocking may include the entire body with the child on hands and knees. Head banging involves when the child is usually prone, repeatedly lifting their head or torso and banging it into the pillow. They can also sit with the back of their head to the headboard and bang on the back of their head. Head rolling is side to side head movements, usually supine. The patient may also rock or roll or bang their arms or legs. Sometimes the movements involve sound. Usually the child will hum. Sometimes it lasts less than 15 minutes after an environmental disturbance or being spoken to. Uh, the interesting things about these patients is that they usually fall asleep while they're doing the movement, almost like it. They have to they have to do it to fall asleep. So why? I don't know. No one knows. These kinds of symptoms are common in normal infants and children. Usually onset is before 1 year old. They can be problematic, especially if it interferes with normal sleep, if it impairs daytime function, or if it hurts the person, like banging their head on the headboard. This is what you might see with sleep-related rhythmic disorder or body rolling. Um, it's a little hard to tell because it would be harder to tell. This isn't really the kind of thing you would see in a sleep thing. Everything has been filtered down. You can see from these 333 microvolt, everything's been turned down and the filters have been applied so that everything looks nice and clean. This is not what it looks like when people are moving around like that. It's going to be disgustingly black and you're not going to be able to read anything. These are the legs. Yes, we see lots of leg movements. But if you were to put all the filters down, this is what you would see. These up and down, it's almost sinusoidal looking waves. That is from the movement of their body rolling. Kids can get restless syndrome just like adults, although it can be more difficult to figure out why children do it over adults. Restless leg syndrome is usually most noticeable when trying to go to sleep, but you can't stop moving your legs. It may show up in the daytime with a shaking knee up and down, but you're not trying to go to sleep or be still then necessarily. It's really a sensory motor disorder involving the irresistible urge to move your legs. It could be described as a restless feeling, creepy crawlies, the need to stretch, or even soreness and pain. Restless leg syndrome may evolve into periodic limb movement disorder, which is when you keep moving your feet or your legs when you're sleeping, and that can wake you up. Restless leg syndrome is often misdiagnosed as growing pains in children. Kids might show more daytime symptoms, like those who shake their legs in school are frequently seen as inattentive and undisciplined, unfairly. 35% of restless leg sufferers complain of symptoms before the age of 20 years old. Kids are pretty good at telling the difference between restless leg syndrome, joint pain, sore muscles, cramps, and nerve compression. It feels different, and they're aware of that, and they can usually voice what they feel. Here's the direct wording of restless leg syndrome from the International Classification for Sleep Disorders, specifically for kids 12 years to adults. Patient reports an urge to move the legs, usually accompanied or caused by uncomfortable or unpleasant sensations in the legs. The urge to move or the unpleasant sensations begin or worsen during periods of rest or inactivity, such as lying down or sitting. The urge to move or the unpleasant sensations are partially or totally removed or relieved by movement, such as walking or stretching, at least as long as the activity continues. The urge to move or the unpleasant sensations are worse, or they only occur in the evenings or at night. This condition is not better explained by another current sleep disorder, medical or neurological disorder, mental disorder, medication use, or substance use disorder. It's pretty self-explanatory. You might hear the word paresthesias. Paresthesias are sensations like prickling, tingling, or creeping on the skin that has no objective cause. The pediatric criteria was developed for those children that aren't able to appropriately describe their symptoms. So you can have either category A by itself, or you can have B and C together to qualify RLS for a 2 to 12-year-old patient. The first condition, A, states that the child meets all 4 essential adult criteria for RLS and relates a description in his or her own words that is consistent with leg discomfort. Otherwise, the child can meet all 4 essential criteria for RLS, but does not relate a description in his or her own words that is consistent with leg comfort, and the child has at least 2 of the following 3 findings: a sleep disturbance for their age, a biological parent or sibling with definite RLS, or a polysomnogram documentation that shows a periodic limb movement index or 5 or more movements per hour of sleep. We are aware of a few causes of restless leg syndrome. First, if a parent or sibling also shows symptoms of RLS, providers will gravitate towards also diagnosing the young patient with it. It's an easy way to get the diagnosis, and it's probably where they got it too. Second, we think dopamine, which plays a large role in muscle movement, sleep, attention span, and muscle and impulse control, may cause RLS if there is an abnormality of how much dopamine is excreted or how much is available or is absorbed. A lack of iron in the blood may also cause RLS because iron assists in dopamine function. There is also some noted association with ADHD, as the sleep disturbance and RLS sensations can aggravate inattention and restlessness. This is restless leg syndrome. The patient, it's kind of difficult to see, but these are like 2 or 3 minute windows. This is about 1 minute here. These are the leg movements. They're just going back and forth, back and forth, back and forth. They can stay still for just a little bit, and then they just have to do it again. This is more of it. This is over 2 minutes. They have little bouts where they stop doing it, but then they just have to keep doing it over and over and over. Bruxism is when a person either clenches their jaw or grinds their teeth together. With sleep, it usually happens right after an arousal. We consider this a movement disorder. Bruxism without a clear cause is primary bruxism and is typically found in healthy children. Secondary bruxism can be caused by psychoactive medications, recreational drugs, or some medical disorders like cerebral palsy and mental retardation. Some triggering factors of bruxism may include abnormalities of the teeth, malocclusion, which is crooked teeth, stress, or anxiety. The prevalence ranges from 14 to 17% in children and approximately 12% in teenagers and adults. In healthy people that have bruxism, there's a cerebral and cardiac activation with microarousals, and then the jaw muscle contractions associates with tooth grinding. Some evidence has found that during and arousal from sleep disordered breathing event, there is sometimes rhythmic movement activity in the masseter muscles. I have personally run a sleep study on a patient with Down syndrome who had apneas and would grind their teeth after every arousal. I have an epic from that record on the next slide to see what that looks like. And that's typical with bruxism. The patient will arouse and then grind their teeth. If they have other problems with arousals like periodic limb movements or obstructive sleep apnea, they can grind their teeth even more. Bruxism can show up as soon as the first baby teeth show up, and if it's a chronic issue, it can cause problems with the alveolar bone as well as TMJ dysfunction. TMJ itself is not a dysfunction. TMJ is the temporomandibular joint, and that is what becomes dysfunctional. It's a joint. So here's bruxism. Right here, you can see it mainly in the chin, and then I1, which is right here, is the one that's nearer to the cheek. It's down instead of up next to the brain, and so that's picking up a lot of the teeth grinding here too. You can kind of see some of this darkness up in the EEG. That's picking it up as well. When you've got two kinds of bruxism, you can still have this and not sound. That might mean they're just clenching their jaw. You can see that. If you hear the sound, it's just awful, and you should probably document that in the notes that you can hear the bruxism. Let's hear what that sounds like. Those aren't rocks, those are her teeth that she's chewing. Benign sleep myoclonus of infancy are non-harmful muscle movements or jerks that happen during sleep. Classified by the ICSD as isolated symptoms, apparently normal variants, and unresolved issues. They are characterized as brief, involuntary twitching of a muscle or a group of muscles. These occur bilaterally. Remember, both sides of the body at the same time, like both hands, both legs at the same time. If that doesn't happen, if it happens on one side at a time, that might indicate a problem. But these happen during sleep without a preceding arousal, awakening, or sleep stage transition. They just happen spontaneously. They most commonly occur in quiet sleep, but they can also occur in active sleep. This doesn't happen for no reason. It's all part of the normal psychomotor development, and there's no increased risk for seizures or anything like that. Sometimes, if these jerks are associated with seizure activity, gentle rocking actually may be a trigger for it. Documentation of rocking and the seizure activity is the most important aspect of such a recording if you happen to have a lab that has a rocking chair or a mother is trying to do that, or a father for that reason. All right, that's it for movements. I would also like you to go through the ICSD. We should have that in the somewhere on our course so that you can actually look at that. The words are all, you know, there's lots of words, but if you can break it down one sentence at a time and understand what they're asking, put it in your own words, that's a great way to figure out how all this stuff works. All right, we'll see you next time.